All right, welcome back to What's Up on KWAT. We've got an in-studio guest. Dr. Ravi Kalaga is a cardiologist at Prairie Lakes Healthcare here in Watertown. Doctor, good morning to you.
Good morning.
Thank you for coming in. Give us a little background on you, your background in terms of education, residency, where you practiced, and how you eventually arrived in Watertown.
That's a long topic, but we'll try to do it very shortly here. I'm originally from India. I did my medical school in India, and then I came over here, did some research for 3 years. After the research, I went into residency at Nebraska Medical Center in Omaha. After that, I did my cardiology fellowship in Connecticut at Yale. And then I did my interventional cardiology fellowship in Arkansas. After that, I started working. I worked for a long time in Nebraska, where I'm from originally. And then I started falling in love with South Dakota, and I'm here in Watertown.
What did you fall in love with about South
Well,
Dakota?
the place, the people. I'm a small town guy. So I like working in small towns, which is what I did in Nebraska. And I started working part-time here at Prairie Lakes Hospital. And I like the people. I like the working conditions. I like the people I work with. And I like the place.
Do you like 25 below?
I'm okay. I'm totally fine with it. And so initially I worked part-time, and then I signed up for a permanent job here.
Excellent. You are a cardiologist. What does a cardiologist do?
Cardiologist deals with the conditions pertaining to the heart. And there are a lot of conditions of the heart. You have people talk about heart attacks, high blood pressure, high cholesterol, which are all the risk factors for heart disease. And then, of course, heart failure and the rhythm abnormalities of the heart. One of the commonest is atrial fibrillation, which a lot of people have. So we deal with, and then the valvular problems. There are a lot of valves in the heart, and those valves can go bad. They can leak or they can become tight. And so we deal with those problems. So multiple structural problems of the heart we deal with, and we take care of all those problems and their complications.
Are there any warning signs, doctor, that someone can notice that might indicate that they are having heart issues?
Yes, there are different symptoms. Again, these symptoms can vary between a man and a woman. There are some gender differences. It's a lot easier, to diagnose heart problems in a man. Classically they come with chest pain, left-sided chest pain. Sometimes it goes to the neck, sometimes it goes down the arms, and a lot of times it is associated with shortness of breath, dizziness, abdominal symptoms, nausea, vomiting, and weakness, tiredness, sudden fatigue, sometimes dizziness. All those things can happen. And in women, a lot of times you may not have chest pain. All they may have is just shortness of breath or just fatigue. Suddenly they become extremely fatigued and tired, and they don't know what's going on. And they might get short of breath, and they might get nausea and vomiting. That could be the only symptom of a heart attack or heart disease. And it varies between man and a woman, but overall, mostly a lot of people present with chest pain, shortness of breath, nausea, vomiting, tiredness. Rarely patients can present with severe headache and weakness. So these could be the symptoms of heart disease.
What is the difference between having a heart attack and having a stroke?
Stroke is mostly related to the brain.
Okay.
So when the blood supply to the brain gets diminished, reduced because of a blockage in one of the arteries going to the brain called the carotid arteries, that can cause a stroke. Or a small clot from somewhere in the body, like the heart or the aorta, the other blood vessels in the body, they can suddenly release a small little plaque material, like a little speck of a plaque, and that can travel to the brain and can knock off one of the small blood vessels in the brain and cause a stroke. Mm-hmm. And a third way of having a stroke is one of the small blood vessels in the brain can split open and cause hemorrhage into the brain, and that can be a stroke. That is totally pertaining to the brain. And there is what is called the mini stroke people talk about, called the TIA, we call it, transient ischemic attack, we call it. And sometimes the blood supply to the brain can get diminished only for a moment. Only for a few seconds it can get diminished, but it comes back again, becomes normal. So those people develop some deficits, clinical deficits related to the brain only for a few seconds to a few hours, and they become normal again. That is a mini stroke or a temporary neurologic deficit which will normalize again in a few hours. Heart attack is completely related to the heart. a blood supply, one of the coronary arteries in the heart can get plugged up with a clot or a blockage or plaque, and that can suddenly cut off the blood supply to part of the heart muscle, and that causes a heart attack. Heart attack classically results in death of the heart muscle. A part of the heart muscle dies during a heart attack because the blood supply has been cut off, and if it's not restored in a very short period of time, the heart muscle dies, and that death of the heart muscle is usually permanent. That's why when somebody comes with a heart attack, we try to act rapidly. We want to go and open the blockage quickly and restore the blood supply to the heart muscle so that we can salvage the heart muscle and not let it die.
I've heard, doctor, people who get stents put in one of their arteries.
Yeah.
What does that mean? Do you do that, and what does
Yes,
that mean?
I do that. That's one of the important things that I do as a cardiologist here. When somebody comes with a heart attack, with a blocked coronary artery, we take them to the Cath lab. We do what is called the cardiac catheterization, pass a catheter to the heart, and do angiography. We call it coronary angiography. We inject dye into the coronary arteries through a catheter and take pictures of the heart when the dye is flowing through the coronary arteries. And those pictures show us all the coronary arteries on the big screen that we have in front of us in the Cath lab. And we can identify which artery is the one that is plugged up. And now through the same catheter, we can pass a wire across that blockage and put a balloon in, open the blockage, and once the blockage is opened, we have to put a stent there. A stent is a piece of metal. And if you just balloon open the blockage and don't put a stent, there is always this mechanism called recoil, vessel recoil. The coronary artery can recoil back and get plugged up again. So what we do, we put a scaffold called the stent that will open the blockage. It's a piece of metal, and it will keep the vessel open like that. So the blood will now start flowing.
So the stent stays in.
Stent stays in. Once you put a stent in, you can't take it out. It's permanently, it's placed there.
It's there for
it's
good.
there for good.
Yeah.
Yep.
When you do a procedure where you put a stent in, that would not be considered open heart surgery.
It's not.
What is open heart surgery?
Open heart surgery is literally, as the term itself denotes, you open the chest and go in and work on the heart. Literally, when the heart is there, is beating, you can work while the heart is beating, and sometimes they stop the heart, and then whatever work they have to do on the heart, they will do it, and then they will jump start the heart again. That is open heart surgery, where you're literally opening the chest of the patient and going in and working on the heart, and then again closing the chest. What I do is not open heart surgery. I do everything from outside through a catheter. It's all catheter based, whatever I do, the stents, angioplasties, and all that. And I don't even put a little cut on the skin. I just go with it through a small needle. I get into the artery of the patient, either on the wrist or the groin, and then pass a fine catheter to the heart, and I do everything from outside through a catheter while watching the whole thing on the screen.
It's amazing. When someone has that procedure done, do they go home the same day?
A lot of times we send the patients home the same day.
Wow.
And it depends on what we do, the complexity of the procedure. It depends on the age of the patient. It depends on how far they live from the hospital. If they are within 20 miles, 25 miles from the hospital, and they're less than 75 years of age, and we have done a fairly straightforward angioplasty procedure with stent, we say we can send them home the same day. But if they're farther away from the hospital, then we keep them overnight.
How big is the heart muscle, doctor?
Heart muscle is fairly big. Heart weighs anywhere between 300 to 400 grams in weight. Okay, depend again in the man. In a man, it weighs a little bigger and a little heavier in a man than a woman. In a woman, it weighs about 250 to 300 grams. In a man, anywhere between 300 to 400 grams it weighs. And so it's a big muscle, heart. And remember, it needs that kind of muscle to pump blood to all parts of your body. It pumps blood through all parts of your body and receives blood from all parts of your body. It is a fairly robust and muscular organ. It is.
Indeed. So what, doctor, can we do, whether it's through exercise, diet, lifestyle choices that we make, what can we do to best try and keep our heart healthy?
Very good question. And it is called preventive cardiology. It is called, that's the term given to that, what you just asked me. And there are a lot of risk factors for coronary disease and heart disease. What you're essentially asking me is to is to come up with certain measures of how to prevent any cardiac problem from happening. In other words, how to modify the risk factors you have. And there are certain modifiable and non-modifiable risk factors for heart disease. For example, if your age, you take age, we all get older and older. We never get younger. Okay, that's age. And the second thing is, for example, your gender. If you're born as a biological male, you are a biological male all your life. So men have a higher risk for heart disease than women in general. Age always goes in one direction. So you get older, the older you get, the risk goes up. And then genetics. You always inherit from your ancestors certain genes from your parents and grandparents, and you can't run away from those genes. Those genes are with you for the rest of your life.
Right.
And if those genes are actually, they are getting certain bad characters with them related to heart disease, you're at a high risk of developing those heart problems. And so you can't run away from your genes. So those are non-modifiable risk factors. And there are modifiable. For example, you have high blood pressure. You can treat the high blood pressure, bring it down, and control the pressure. High cholesterol, medications, diet modification, avoid too much of saturated fat, red meat, and all kinds of deep fried food. If you avoid all those things, your saturated fat intake goes down, your bad cholesterol level goes down. That way you don't form plaque in the coronary arteries of the heart and cause problems to your heart. So that is a modifiable risk factor. Same thing, smoking. If you are a smoker, you have in your thing to quit smoking if you want to. And if you quit smoking, your risk goes down. And exercise. If you don't do exercise, you lead a pretty sedentary life, then you are at a much higher risk of developing heart disease, as opposed to if you're exercising on a regular basis, at least 20, 30 minutes of good exercise every day. If you do that, then your risk is far lower. And so these are all the modifiable risk factors: high blood pressure, diabetes. For example, if you're a diabetic, you can take medications to control your diabetes level, your sugar level, and also eat good food, not food that will increase your blood sugar level and cause problems with your diabetes. So there are these modifiable risk factors where you have some control over, that you can exercise some control and bring those things down. Non-modifiable, you don't have any control over those.
Sure.
So these are all the risk factors. There are other certain novel risk factors which are rare. And if you can exercise control over all these risk factors, then you will definitely help yourself in cutting the risk of heart disease down.
If you are experiencing some of the symptoms of heart disease or a heart attack, like shortness of breath or pain down one arm, how important is it to get in and get checked out rather than think it'll just go away?
Very good question again. We face this problem pretty regularly. A lot of patients, particularly men, who ignore the symptoms of heart disease. When they get chest pain, they think it's probably some acid-related problem, or they must have pulled a muscle in the chest, they think, and they ignore that, and they take a long time before they realize that, oh, this is not going away, we need to go to the hospital. If it is a heart-related problem, then you're letting your heart suffer a lot of damage in the process. What I suggest is, if you have any of the risk factors we just talked about, and if you are more than 50 years of age, generally speaking, it's not that if you're 40 you should not take more precautions. If you're generally about 50 years of age, then you should definitely be proactive. And if you develop any one of the symptoms that you just said, get yourself to the hospital and let the doctor make a decision. Let them do a few tests, quick tests, and decide whether it is heart-related or not.
What is heart bypass surgery? Because we hear that term used too.
The thing is, if you have multiple coronary arteries involved in blockages, for example, there are three main important coronary arteries in the heart and their branches. And if you have blockages in all the three arteries, or some of the arteries are blocked at very strategic points in the heart, then it is probably not a good idea or a wise idea to go and put balloons and stents there. So in such patients, we send them for bypass surgery, where they open the chest. Again, it's an open heart surgery. They open the chest, stop the heart, and then they bypass the blockages with grafts. Those grafts are generally derived from your own body. They take veins from your leg, and they transpose those veins on the heart and create these grafts. And literally, as the term itself suggests, they bypass the blockages and implant those grafts in the heart so that now the blood flows through the grafts to the heart muscle, bypassing the blockage.
So you see patients that you think might be a candidate for stents,
Yes.
and upon more further review, they need a heart bypass rather than stents.
That's correct.
Okay.
And we refer them to Sioux Falls or other places for bypass surgery because we don't do that here in Watertown.
We'll talk about the cardiac cath lab. What is that?
Cardiac cath lab is where I do all my procedures, my angioplasty procedures and heart and coronary angiograms. And it's a nice, beautiful place where you have all the equipment that you need, where we do sometimes emergency angiograms on the heart and find the blockage and open the blockages and put stents. We have a very well trained staff in the cardiac cath lab, and we have a lot of equipment there, a nice table and a big camera with x-ray equipment. And we have all this material related to the stents and balloons and wires and all that stuff. We have all those things right there in the cath lab, what we need. And that's where we do all our procedures.
What happens during a stress test that might indicate whether someone has a blockage or not?
There are different types of stress tests again. One of the stress tests that we commonly do here is a treadmill stress test where we put the patient on a treadmill. And the second one is a nuclear scan of the heart where we can put the patient on the treadmill and after a certain exercise we inject a radioisotope. We call it a radio tracer. And then we scan their heart before exercise and after exercise. And we see whether there's any difference in those scans. And if a certain coronary artery is blocked, then that part of the heart muscle where this artery is going, that will show up as a perfusion defect on the scan. A defect on the scan is seen when a coronary artery is plugged up. So we then, from those scan images, we draw conclusions as to whether the patient's stress test is abnormal or normal.
During your years in medicine, doctor, what advances have been made in technology in diagnosing and treating heart problems?
So there's a lot of advances. 20 years ago, what we did for cholesterol control and high blood pressure control and all that, we do a little more differently now. And we have new medications, new technology in treating these conditions. And even in the heart, for example, in the past, if you had a valve problem in the heart, those patients always were sent for open heart surgery to take care of the valve problem. Now, a few of the valve problems are dealt with not with open heart surgery, but through a catheter. Just like I do an angioplasty, they pass a catheter all the way to the heart and deliver a new valve in the heart. We call it TAVR, and those valves can be delivered through a catheter, and the patient can be sent home the next day, or the same day sometimes. That's a giant leap in science and technology and medicine. And a lot of other things are coming up, new technology is coming up. And as time goes by, the so-called minimalistic approach. Try to do minimal surgery on the patient. If you can do the surgery through a small hole, why cut a big hole in the patient's body? So the same thing, if we can deliver a new valve with a catheter, why do an open heart surgery and keep the patient for 10 days in the hospital? And everything is getting minimalistic now.
Indeed.
If you see it 10, 20 years from now, I can't even imagine where the cardiology technology will be at.
Very interesting information, Doctor. Thank you for coming in this morning. It was good to visit with you. Anything in closing that we maybe haven't touched on?
First of all, thanks for giving me this opportunity to talk about cardiac conditions and cardiac problems. And Prairie Lakes Hospital, we are taking care of our patients really well. We give a more personalized approach to all the patients. Yes, so if you're living anywhere in Watertown or close by and you have any cardiac problems or you think you have some problems, or even we talked about preventive cardiology, you want to prevent cardiac problems in the future, think of Prairie Lakes Cardiology, and we are here to help you.